Hello, everybody. This is Mark Lynn with Healthcare Business Specialist in Chattanooga, Tennessee, and this is the Preparing for the RHC Certification Inspection on May 20th, 2021. Here's my contact information if you do need to get a hold of me. Danny Gilbert is going to be with us today, and she will be watching the questions there. So if you have questions, you can type those in as we go through this presentation. What Healthcare Business Specialist does, here's just a listing of all of our services that we provide for rural health clinics. We only work with RHCs. So if you need us for anything, let us know. We'd be glad to help you. If you're not already a member of our Facebook group, we have 2,400 people or so that are members there, and there's lots of great information that is shared. Wonderful way to ask questions and find out what other people are doing, and they are very helpful in answering questions for you guys. So it's a good resource. We are having another webinar very soon. This is going to be on the grants, the grant applications that are going to be due, and how to use SAM and DUNS and grants.gov. We have an expert, Elizabeth Burrows, who I've been referring business to for years and years and years. She is going to be, she will be presenting for us. So that will be your go-to resource on all of these grants and DUNS and questions like that. I'm starting to get them right now, and I'm like, that's not what I do. So we'll refer all that to Elizabeth, and she's very good. So if you haven't had a chance to sign up for that, I know yesterday we had a great webinar with Nathan and Bill. They really walked through a good portion of this. Hopefully by next week we'll have the grant application out, and then Elizabeth can tell you some more about that. And she said that she had some more detail on how to do the grants.gov website as well. So she's not going to repeat what was said yesterday, because you can get the recording of that and watch that. So that's going to be next week as well. We do have a website called ruralhealthclinic.com where we have lots of information. If you click into resources, you will go into a page that looks like this. So then you can go in, and if you have issues with emergency preparedness, certification materials, RHC past seminars, billing materials, cost reporting, all those we sort of have different resources for you for each one of those sort of general topics for RHCs. Here's what the billing one looks like is when you go into it, and you'll see some past recordings of webinars we've done on how to do RHC billing. We don't have those things up to date. We normally do them every January, but due to COVID, things are a little bit different, and we just didn't get a chance to do it, but we will try to get that done after August 2nd, when all the RHC cost reports are due. We'll probably work on that. So questions, if you have questions, you can type them in there in the bar there. I see somebody, looks like they've got a question already. Danny, what's the question in the sidebar?
It was just somebody was having issues hearing. I messaged her.
All right, good deal. Yeah, I mean, we are dependent on bandwidth, and to make these things work. We're lucky. I live in Chattanooga, Gig National, Gig Central, whatever they call this place. We have really good internet where I live versus a lot of you rural areas there that don't have the greatest internet in the world. We don't really have a problem with that in Chattanooga. The session is being recorded. We will put the slides on our Facebook in that RHC information exchange. We'll also put them on our website. I did put it in the sidebar over here in the handouts. That may or may not work. It probably works about a third of the time, because typically my slides are very image. There's a lot of images in them, and they tend to not work when you try to download them from this sidebar over here. So I don't really know a way to fix that. I guess I could be less visually oriented, but that's the way I tend to learn. Everything was updated as of today. I think I finished this slide presentation about 2 minutes before we went on, and so we will give you some general guidance. The session is being recorded, so if you have an issue with being recorded, please, you're welcome to leave. So preparing for the RHC inspection, what we're doing is we have people that are brand new RHCs, and we have people that have been RHCs for 30 or 40 years. and they may be due for some RHC re-inspections. Typically, the states will come out every 3 to 5 years and do re-inspections. So, and because of COVID, the states have gotten behind, and a lot of states aren't coming out yet to do resurveys. I know in Tennessee, they told us the other day that they're still not coming out to do resurveys, but other states are opening that up and going back out to do resurveys. So if you were expecting one in the last year or so, expect it pretty soon. So there's 9 conditions of participation to be a rural health clinic, and what you're trying to do is prove to the state or Quad A or the compliance team that you have met those 9 conditions, and that's through your documentation in the clinic. You can receive standard level deficiencies or condition level deficiencies. A condition level deficiency means that you have not met those 9 conditions of participation in the RHC program, and if you're a new survey, then they're going to come back and resurvey you to make sure you've done it. If you've been in the program for a while and you have a condition level deficiencies, then they will go towards the process of terminating you from the program unless you fix that problem within the allotted amount of time. And you typically will have 10 days. They'll send you out a statement of deficiencies, a 4767 form, and it will list out the deficiencies you have. You have 10 calendar days to respond with a plan of correction. What you want to do is respond to that immediately or get it to your consultant, whoever's helping you with it, immediately. Don't wait till 5 p.m. with 67 pages of deficiencies and 3 or 4 terminating condition level deficiencies, and send that to your consultant and say, hey, do you mind getting that to us by 9 o'clock in the morning? That really doesn't make anybody very happy, let me tell you, especially Mark Lynn. I get angry when that happens. So don't do that to whoever you're working with on that. If you get one of these listings, get working on them immediately, because they are hard to fix and they take a lot of time. So do that. There's 3 types of people that will be coming out to do inspections. The state will come out. Those are for free. You don't have to pay for those. That's what most people have. Some people do have Quad A, and some people have the compliance team. Those are both great accrediting organizations. I tell people I'm agnostic towards either one of them, whichever. They're both great to me, and I believe in both of them. So both of them just do great jobs. So we're very pleased with them. So depends on some states. Some states will not come out and do initial surveys. You have to hire Quad A or the compliance team to do your initial surveys. If you're in one of those states, here's the information where you can get a hold of Kate or ALC or Tom at Quad A. So here are the 9 conditions of participation to be a rural health clinic. And then this, if you want to click into here, you'll go into this Cornell Law School. This is the best resource to get these. If you read these, there's probably about maybe 12 to 13 pages. There's not a lot of reading to it. So the first condition of participation you have to do is you have to meet all federal, state, and local laws. Typically, your state scope of practice supervision for your nurse practitioners and PAs, that's a big state law that you have to worry about. And then you want to show, you want to have a poster and post in your break room about all the federal, unemployment laws and minimum wage and OSHA, all those types of things. You want to have that poster out there as well. This is some major things. You must meet the location requirements, which means you have to be in a non-urban area, not rural, but a non-urban area that has been updated within the last 4 years. And then that one's relatively easy to meet. Physical plant and environment, you have to have a safe environment for your patients and your employees. You have to do drills. It has to be clean and free of clutter. All sorts of things like that we'll go through. You can typically pick up with a mock inspection of walking through your clinic and doing a good mock inspection. You'll pick up any issues that you have there. Organizational structure, you have to have a medical director in a rural health clinic. They don't have to physically be on site. In 2014, they changed that rule where used to the medical director had to physically be on site once every 2 weeks. That is no longer the case, but they are required to do certain things, and we'll go through that as we go through the assigning duties section of this presentation. Staffing and staff responsibilities. You have to have a nurse practitioner, PA, certified nurse midwife, treating RHC patients at least 50% of the time the clinic is open, and that person who meets that 50% requirement as of this moment has to have a W-2 relationship according to the regulations. Now, you can hire people on top of that, if you want to contract with them and do a 1099, you can do that. But if you want to stay compliant with the current regulations, that is a relation. Hopefully they'll be changing that. That's a stupid rule. It doesn't affect patient care whatsoever. I don't know why the government would care if somebody get a 1099 or a W-2, as long as I guess the IRS would care, but that's their business, not patient care, which is what we're worried about. Provision of services. What we're looking for there is you must be 51% primary care. CMS identifies primary care as being, family practice, general practice, pediatrics, OB/GYN, internal medicine. All of those will be considered primary care for that purposes. Where you run into issues is mental health and Suboxone and those types of services. Those are not considered primary care by the government, which they should be. I mean, as we all know, they really are primary care now, but as of this moment, they're not. And you can run into issues there if you have more specialists or more mental health services than primary care, then you would not qualify as an RHC. We've had a couple of our clinics where the government has tried to take their RHC status away because they were providing too many mental health, Suboxone types of services. Patient health records, HIPAA's been around since 1994, so by now we should have figured that out. The key thing there is your consent to treat. Consent to treats must be signed within 1 year for most of the surveyors that we deal with. Most of them will come in and pull 20 charts, and they'll go through and see if your consent to treats are up to date. If they're not up to date, you will get written up for it, and it's really not a fun one to fix. So you want to make sure you do that. Program evaluation, you are required to have write a report. You're not required to have a meeting. So a lot of people get confused and think, oh, we have to have this big meeting, have a lunch and learn and do all this sort of stuff. No, you don't have to have a big meeting, but you do have to write a report. And that report has to be signed by the medical director, by a nurse practitioner or PA, and by a community member. A community member is somebody who is not employed by the clinic. We as consultants, Danny and I, we tend to be the community member for a lot of rural health clinics, getting them up and started. But what you really need is somebody in your community, maybe a doctor, nurse practitioner friend, pharmacy friend, maybe the mayor, somebody like that to sign off on these reports and review your policies and procedures. And basically every 2 years is what is required to be done right now. So program evaluation used to be used to call it annual evaluation. Now it's every other year. That is the requirement now. And I always have to say, except for Louisiana, they never changing. They didn't change these rules, and so I think it's required every year in Louisiana. The emergency preparedness, I know in Louisiana, is required every year because God bless them, they seem to be having emergencies every time we turn around, and thoughts and prayers are with them as they've got another one with all the floods and stuff. So emergency preparedness is something that was added. The law came out in 2016, became enforceable in 2017. So it's been a bunch of years since you had a site survey from your RHC state inspectors and you haven't done anything on emergency preparedness. You better get to work because it is a lot to do. You have to have a policy and procedure manual. You have to show that you're doing a drill. Right now you have to do 1 drill per year. You have to do a risk assessment every 2 years. You have to train your employees every 2 years. You have to have a communication plan that's a fluid plan that's updated. It's on an ongoing basis. So if you hire Mark Lynn as an employee, then you've got to put me in your communication plan. And if you fire Danny Gilbert, which you would never do, but if you fire Danny, then you would remove her from your communication plan. So that's a fluid document that's pretty much updated on an ongoing basis. And so And then you also need to reach out to community leaders. Some question about those rules that changed a couple of years ago, whether you actually have to do that anymore or that you just don't have to document it anymore. The best practice and the reality, the only way to comply with these emergency preparedness rules is you really do need to reach out to those EMA directors in your community and work with them to be sort of a shared burden for any of these types of emergencies like we're seeing in Louisiana right now. So those are the 9 conditions of participation that we are working to show that we have compliance with. We only have an hour to do this, so we're going to provide you with a bunch of resources that will help you in compliance. And this is a great document. This has just come out a couple months ago. The NARHC put this together, and it is really, really good. So I use it all the time. So the first thing is on here you see the top of the triangle there, statute. Statute is legally blinding and binding, but that's what we showed you before, the Cornell thing, those like 8 or 9 pages. That's what that's talking about. And then the second level here is RHC regulation. That's stuff that CMS puts out, and it's not much more than the statute as far as number of pages. Typically, I know the emergency preparedness rules that came out were only 2 to 3 pages long. So that it's not huge, but those are the regulations. That is legally binding. And then RHC guidance. These are things like Appendix G and Appendix Z. And those are not legally binding. So you can, having issues here, I can't breathe. so those are not legally binding. Those are just interpretations of the rules. So you have a little wiggle room to argue with the inspectors on that. We had an inspection a couple weeks ago, and we were very nice. I played dumb, which is very easy for me to do, and just said, well, what about this? And sure enough, they said, okay, yeah, those 2 items will go off the table. You're right. We don't have the authority to do that. So we got no deficiencies on that one there. So if you're not a member of NARHC, please consider joining. Oh my goodness, your fees have been well worth it this year with all the things that they've done for rural health clinics and the lobbying that they've done. It's been amazing. Here's what Appendix G looks like if you ever want to go into and look at its 89-page document. And then Appendix Z, that's a 74-page document. These are updated on a periodic basis, so you want to look for those updates that come in for that. Be careful in Appendix Z because it covers things for hospitals, transplant centers, long-term care. There's a lot of stuff in there that's not related to rural health clinics. So you pretty much have to just search for RHCs and look at the regulations that are specific to RHCs, because you don't want to be going out buying a generator and stocking up your rural health clinic with 4 or 5 days of food and medicines to shelter in place when you don't have to do that. This here is an RHC fact sheet. It was last updated in May 2019, so that one needs to be updated as well. But that's still a lot sooner to now than May 1978, which is the CMS survey form 30. That's what a lot of the state inspectors use. So believe it or not, in 43 years, a lot has changed over those years. And sometimes the state surveyors will cite you something in there or try to cite you something in there that changed in OBRA 90 or CLIA 94 or whatever. And so we'll have to, if you basically take this document, send it to them, and it has the current regulations as of 2019 anyway to them, and that will help you avoid getting a deficiency for not being able to do a gram stain or a pinworm test, which occasionally we'll see people do that. To keep up with the current RHC rules, the CMS has something called the Rural Health Clinic Center. It's a website, and it has all of the state operations manuals on here. I gave you a snapshot of it over here, but it's like there's 6 pages of stuff on there of links of information, and you will find pretty much anything you want to know about rural health clinics on there. There is a link here. If you click right here where it says Medicare certified RHCs, you'll go into something called QCore. And QCore is very helpful. You can look up active RHCs. So I know exactly how many RHCs are. I think there's like 4,800 RHCs in the country right now. You can break it down and look by state, and they'll print you out. You can actually print off a listing of all the RHCs in each state. So it's very, very useful. Here we're looking for overdue certifications there for people that are expecting surveys. So we have 32 people here in Tennessee where I live that should be, these are late surveys as of a couple months ago when I ran this report. Those people should be expecting a survey. So that's probably, if you haven't had a survey in a while, you may want to run this report just to see where you stand on that. As far as our website goes on ruralhealthclinic.com, on our section called certification materials, we are always updating this on a pretty regular basis. You can see where here's the stuff we just added not long ago, February 23rd, 2021. We're going to talk about an evidence binder, and we put tons of information about how to do an evidence binder. Our philosophy is if you want to do it yourself, you go to it. Here's our documents. We'll put them on there for you and let you guys go at it. You do not have to pay us to do this for you. You're just as smart as we are, so you can do that. And then we updated it again last week. With the pipeline being down, everybody was asking about a HIPAA risk assessment last week, so we stuck that on there. Typically when somebody asks me to have some information, I will put it, I will look it up, and then I'll stick it on that website for you. They were asking me about OSHA training. So here we have something, we have a little webinar on OSHA training. Somebody asked me about HIPAA training. So there'll be a HIPAA webinar link on here probably tomorrow. So we also have a very quick little 15, 16-page document that that people can use when you're starting up an RHC. This is our conversion process when we're starting up new RHCs for people. And you're going to be in phase 2, where you're going to be going through and pulling all this information together for showing that you're ready for the survey. So I would definitely use that. A lot of products, if you don't have these particular products, like a rural health clinic is required to be able to do 6 basic lab tests, which are listed here. The hard one is the hemoglobin or hematocrit, and you can buy this pulse ox machine from Massimo, and they're at the NARHC meetings when we do the live ones. They're there all the time with this little pulse ox machine that costs about $500 or $600. There's another supplier of it as well. So this is just a way to go through this stuff and buy the little things that you need very quickly to become a rural health clinic. And then we have a lot of forms on there as well. Arkansas has some great resources here. This is a video. This is Steve Zimmerman. He's Kate Hill's boss, and he did a great survey, a great presentation on preparing for a survey. This is the one that I listen to all the time. This is Kate Hill. In Oregon, they have great resources every week. They have a webinar every week, so it's fantastic. So definitely subscribe to their YouTube channel because you will get a lot of great information there. And if you click here, you'll get Kate's presentation. You'll see that I stole a bunch of stuff from her. I'm sorry, Kate, but your information is really good. And she is the authority. She's an RN, Army decorated. My goodness, we love Kate. So she's on National Association of Health Clinics board, as well as the National Rural Health Association board as well. And Kate and Elsie's from Quad A. They did during the middle of the pandemic, we did a mock inspection of a rural health clinic where we basically walked through a clinic, and I would ask Kate, now what are you looking for in the patient exam room? And Kate would tell me, well, at TCT we look for this. And I would ask Elsie, what does Quad A look for when in the laboratory? And they would tell us what they're looking for. So it's a little bit long. It's like an hour and a half or so, but if you haven't had an inspection in a while, that's a really good resource for you guys to go through and look at that. So,
Mark?
Yes,
We've got a few quick questions if you want to touch base before you dive into the next part.
Let's do it.
All right, the first one, and they deal with the conditions of participation.
Yeah.
One, Pamela asked, when you said the location has to be updated, what does that mean?
What that means is you can go into a website called MI Rural, and if you type in your address in there, it will tell you if your area is in a HPSA, a health professional shortage area for primary care. That has to have been updated within the last 4 years for you to be eligible for RHC status. So that's what I'm talking about there. In your area has to be in a non-urban area as well.
Okay, and Allie asks, what about urgent care? Is that considered primary care?
It is, yeah. Urgent care is definitely primary care. So we do have several urgent care centers that are rural health clinics, and there's no problem with it. So that's good, great question. I should have put that in there.
Okay. Can you repeat the requirement for the program evaluation?
Repeat the requirement for the program evaluation. It must be done every other year, biennially. It must be signed off by the medical director, by the nurse practitioner or PA. Just one of them. You don't have to have all of them sign off, but at least one of them. And it has to be signed off by a community representative. And then there's a bunch of steps on there, what you need to do for your program evaluation. I would recommend just going to our website. We have a template of a program evaluation. Go onto the website and pull off that template and then do the steps that are within the templates, what I would do. So, okay. And we will have a webinar in the future, probably be after August 2nd when all the cost reports are due, but we will have a 1-hour session on just doing a program evaluation. But I would just pull the template until then. Okay.
The last one, would a board of director comply with the community member requirement if they are not employed by your clinic or the parent CAW?
I'm not for sure about the answer on that one. It's probably okay. The only guidance we've ever had from CMS was something that was published in the late 80s. And it said that as long as that person wasn't above the on the chain of command, if like it's in a hospital system, if that person is above the RHC in the chain of command, then they could not be the community representative. So like the hospital administrator couldn't be your community representative, but they would allow somebody like that's in medical records, quality improvement, they could be that person. So the board of directors sound like it would be above them, and if you're using that logic, they probably shouldn't be the community representative. But again, that document that I'm quoting is from the late 80s, and I've not seen hide nails from it since then. So it would probably be okay, is what I'm saying. It's just using that old document. This is one of the times when I know too much about something to be helpful, I think is what the problem is. All right, go ahead. Next question.
Yeah, that's it so far.
Okay, perfect. Okay. Preparing for the RHC inspection, here's the steps to go through. Number one is you need to, if you don't have a policy procedure manual, get one that's specific to RHCs. What we do is we have a policy and procedure manual that's specific to those 8 conditions of participation. That's all we address in there. We don't address how much vacation you guys have or what your benefit packages are, or anything like that. You can do that in a personnel manual, but we do address those 8 conditions of participation. And what I would do is if you already have one, then just update it. In the last year, you've had COVID-19, you've had all sorts of things. You had emergency preparedness stuff that's come in that you have to do. So update those policy and procedure manuals every 2 years and then sign off on it. Same thing, we have a separate emergency preparedness policy and procedure manual because it's so thick. We have about 170 pages of our EP manual. You can actually we actually provide you a copy of that for free on our website at ruralhealthclinic.com/emergency preparedness. I probably shouldn't do that, but I do. And you can just take that and search and replace and use that. But you do need to have that thing updated with it every 2 years and sign off on it. Make sure you got all your employees trained on emergency preparedness, OSHA, HIPAA. For emergency preparedness, you only have to train them every 2 years, but for OSHA and HIPAA and all the other types of training you have to do, that should be done annually. So you need to have proof that you're doing that training. Start acting like an RHC. If you've not been an RHC before, we have all sorts of forms. You need to document it. The old nursing adage, if it's not documented, it's not done. And that applies to rural health clinics. So you want to make sure that you're doing that. You do have to do, if you haven't done this before, you have to do at least one drill. You have to do that before you get surveyed. So one drill per year. It used to be two. It's only one now. So, and to count as an emergency preparedness drill, you have to have what's called an after action report. You write this big report saying what you did and what you learned and what you could do better at, and that's called an after action report. You have to do what's called a risk assessment, which is what things are out there that can kill me in Chattanooga, Tennessee, where I live. And the great thing about those risk assessments is you don't have to do it all on your own. There's lots of resources out there. If you just Google risk mitigation plan for Hamilton County, you will find a 500 or 600 page document that tells me about all the floods and all the tornadoes and everything. And you will have one of those for your area as well. Again, train your people on emergency preparedness. That's the thing you do every other year. You do have to do a program evaluation, even if you're not in the rural health clinic program. If you've been in business for over 1 year, they will require you to have that program evaluation. If you've not been in business for 1 year, then you'll have to have a template of that to where what you would do, which is one reason why we have it on our website for you guys, so you can have that templated program evaluation. Then I would conduct a mock inspection where you physically walk through the building and just wander around and look around and see what's going on, making sure that everybody's doing what they're supposed to be doing as far as your policy goes. And we'll tell you there's one deficiency that people have been, I think we had 17, according to Kate, she had 17, I think maybe 22. I think in the RHC meeting, the number had gone up to 22 inspections where people have gotten condition level deficiencies in the last year because it's one item. So I'll tell you that when we get to that point in a minute. And then evidence binder, we'll emphasize an evidence binder for these RHCs. That's the number one thing you can do to help you stay in compliance and get through the state surveys, is to have a good evidence binder. Okay, policies and procedure manuals. Again, we help you with emergency. We have an RHC procedure manual. We have an emergency preparedness policy procedure manual, but we don't have HIPAA, OSHA, all those other types of lab manuals, personnel manuals, administrative manuals. We don't really do that for people. You're going to have to do those on your own. There are some really good resources for this. OSHA Guard, OSHA Guard is really good for this. HIPAA Trek, if anybody knows Sarah Batterman, she is great on HIPAA. But you do need to get all these things up to date before the inspection comes about. You typically won't get written up on HIPAA and OSHA and all that, but they will just sort of double check to make sure that you're doing all that to get updated. So keep that in mind. These manuals do have to be approved by your professional advisory group. That's the same group that I said that has to sign off on your program evaluation. That's going to be your medical director, your nurse practitioner, PA, and that community representative that's not employed by you. So there's a lot of good resources out there. These are just a few that we've run across that are good. The most important step to passing the RHC inspection is a good evidence binder, yes or no? The answer to that is absolutely yes. You definitely need a good one. When we do a startup for our clients, we put together an evidence binder for them. Here's our current table of contents. It's got 25 tabs in it. And there's the information that we request for them to pull together for the inspectors. What we do is we ask our clients to make a copy of the evidence binder. So when that surveyor shows up, they're going to give me a list. They're going to give me a little list that says, here's the information I need from you, and you're going to hand them back a expandable folder with copies of everything they would ask for, so they can have it. They can get in and get out. I talked to one of our clients this morning. We do what's called an after the survey webinar with them, saying, okay, what's our next steps? And so I asked him about, well, how did the inspection go? And he's like, well, no deficiencies. The surveyor said, well, these things normally take 2 days for us to do, but he was able to do it in 5 hours. So, and I think a lot of that has to do with that evidence binder being really, really good and having him to get his stuff in and out of there quickly. And the whole goal for the evidence binder is to get your surveyors in and out of there, because we all know the longer the people stay in there, the longer they have a chance of finding things. I wish we were all perfect, but as of right now, haven't met anybody yet. Your evidence binder should be maintained continually, and then and I said here's the key here: make a copy of it and give your evidence binder to your inspector. Let me see here. Inquidocs, if you don't know Patty Harper, she is fantastic. They have a computerized system that does all this for you. So you may want to talk to Patty. Yeah, a lot of our folks just aren't as sophisticated as that, but they do have they have an online evidence binder that's relatively inexpensive for what you get, and so you may want to look into working with Patty on that, because Patty's brilliant, so that's really good. Here's some of the things that you would have in your evidence binder. Your license. Make sure you're going to do all your credentialing, get all that caught up. If you're brand new and you haven't been an RHC before, I would keep a schedule on your nurse practitioners and PA's time, because you're going to have to prove that 50% rule, that they're there 50% of the time that the RHC is open. You're also going to have to calibrate your equipment, any type of medical equipment you have. Go out and hire a biomedical company to come in and make logs and do invoices that prove that you've calibrated your EKG machine or any type of electrical equipment that's going to touch that patient. That has to be calibrated every year. Make sure you get your CPR certificates up to date. My daughter went to work for a physician practice this week, and she had to get her CPR done before she started work there. So she's going to Nashville this weekend and get her CPR done, which she did. So I'm so proud to have a child that's actually working. So chart reviews by your medical director. We'll talk about those. Drills, you should have basic drills. These don't have to be the drills with the after action report, but just some basic drills on evacuating the building, what you would do in case of a fire. You need to document that, and then call the fire department. I know in Tennessee, they've been writing people up for not calling the fire department and doing that annual inspection. So you'll want to do that as well. Let me see, and this is the form that Tennessee will give you. When the state inspector walks in, they're going to ask for these 21 items. We actually have, for the ones in Tennessee to work with, we actually have an evidence binder, this little blue binder that we put all this stuff in there for them, and we just hand them the blue binder, and believe me, it gets them in and out very quickly. Credentialing, you're going to want to make sure that everybody's credentialing is up to date. This is a form that TCT uses, and so just put all of your license members here and go through and make sure that everybody's credentialed. You need to do this anyway to keep your credentialing up to date with your insurance companies, but you want to double check this and make sure you're doing it before that. And then go through all the personnel files as well, and make sure you have all of this stuff. I-9 form. I helped Asher out your I-9 form the other day when she got her first real job. Job descriptions, or stuff here. Here's one in Tennessee that will get written up for TB and hepatitis B, those signs that they decline that, or if you need to give them the vaccination, you need to have those records in there so those can be reviewed as well. But this is a great form by TCT that I would just go through and make sure that you have all this stuff here. You also need to check and see if the person's been excluded from the Medicare program. We were doing one of these yesterday for a client as they're getting ready for an RHC inspection, and dadgum, she showed up on this list. We had to get her social security number and found out that it was another Lisa Smith, that it wasn't our Lisa Smith that we had hired. But you need to do this on a monthly basis. I know Patty tells me this story about, she had a client that they found somebody that was on this list, and they didn't find it until about 3 or 4 months after they'd hired that person. They ended up paying back $300,000 or $400,000 to Medicare and Medicaid because they'd employed somebody on this list. So that sort of freaked me out. So we make sure that our clients do that before they go into the RHC program. Here, I look through everybody. I'm not excluded from the Medicare program, just a miracle at this point after 35 years. But I checked everybody, and we're good to go. Do your training for your employees. Remember, not just RHC training you have to do, but you do have requirements as a medical practice for HIPAA, for OSHA, for all these things. Nobody can be an expert in everything RHC and everything medical. So here's some companies here that can do all this training for you online. You basically watch videos and then do online tests, and they give you a certificate. And those are a couple of good ones that you do. Also, competency. Remember your nurses, and remember, it's, depending on what state you're in, some states require MAs to be licensed. Other states, like Tennessee, do not. So others out there doing all sorts of wild things that I'm like, wow, you can really do that. But you have to do competencies to do that, and then you have to have proficiency. Once you've been competent in doing it, every 6 months or so, you need to go back and test the proficiency of your nurses, of your MAs, of your patient caregivers to make sure that they're still proficient in doing what you ask them to do on a regular basis. Okay, and assigning duties. We have a little 24-page document here that shows the things that you need to do as a rural health clinic. Basically, you want to assign duties to your medical director. They don't really have a whole lot to do except sign off on some medical charts and sign off on some agreements, and then help you decide what to put in your emergency kit. And these rules changed a couple years ago. It used to be every you had to have 8 categories of medications. Now you just look at your community history, the medical history of your patients. Are you a pediatric office? Are you a geriatric office? Do you have a lot of Hispanic or maybe African American patients? That would change what you would have in your emergency kit. And so you think about those things and then come up with and there's the source for that. And then there's the TCT standard for that. You come up and just write up a policy that says you have the following items. And typically in a rural health clinic, it's very, very limited. You don't want to put a ton of stuff in there if you're right across the street from the hospital. Basically, some Benadryl or epinephrine you're going to put in there, maybe aspirin, nitrostat, or if you're in the middle of the opioid belt there, Narcan, maybe something you put in there. But you decide what you want, what you feel competent about administering, and think about how far you are away from emergency services. Try to keep it as minimum as possible because you're going to throw away thousands of dollars of stuff. If you go out and buy a Banyan kit or a crash cart, you're just going to be throwing money away. Chart audits. This is one of the most confusing things to me for rural health clinics. There's basically 2 separate chart audit requirements for an RHC. First off, the state. You have to go by whatever the state laws are on the state scope of practice for working with your nurse practitioners and PAs. Every state has different rules. Fortunately, most of the states have really relaxed those rules where nurse practitioners and PAs can, a lot of states work independently from a physician where there's not requirements to oversee and to review 20% of the charts. Last time I checked in Tennessee, I think our rule here was 20%. The physician has to review 20% of the charts monthly. And typically with electronic health records, it's very easy to do. They go in, they sort of star the charts that the physician needs to review, they review them and electronically sign them, and the physician is never anywhere near the practice. So that works great. But make sure you look at your state law and follow the scope of practice for your particular state. Now, there's a second level, and I use it. Some people say you got to do whichever one of these is more. I always just say and do both of these. And so from an RHC program evaluation standpoint, and if you read the interpretive guidelines, which are not binding, by the way, they're not binding, and we think they're going to come out with something different very soon. But as of right now, we don't have anything different than what those interpretive guidelines say, is an administrative review of the lesser of 5% or 50 charts annually. I just choose 50 charts because that's just the easiest way to do it. So these reviews for the program evaluation purposes do not have to completely be done by the physician, but the medical director must sign off on them, and the nurse practitioner and PA must sign off on them. And what we recommend, and there's nothing magic about your policy, depends on what you want to do. If you've got brand new nurse practitioners there that that are green as grass, you may want to do, 50 charts a month or whatever. And you may have an old salty PA or nurse practitioner, somebody like me that's been doing it for 30, 40 years. You may want to do less, but I say at a minimum, we need 50 charts reviewed annually at your clinic. It's not based upon not per nurse practitioner or PA, but in total, you need that. And what you want to do is keep up with those chart reviews and put those as a part of your program evaluation every 2 years, because that is a part of that program evaluation. And one of the requirements is you have to review closed charts. And what we define as a closed chart is if the patient has died, that's going to be a closed chart. You're not going to be providing much medical care for the dead patient, I hope. And if they've transferred to another provider, somebody didn't like Dr. Mark Lynn, which how could that be? But there's some people out there that don't like me, and so they're going to transfer to somebody else. We want to see why people didn't like that. Sorry, Mark Lynn. And then if the patient has been inactive for 3 years or more, you want to review that chart as well. Those are what's called closed charts. And so what my policy I think I would do is if you have anybody that passes away in your practice during the month, just pull the chart, visit that graveyard, and see, was there something we could do better? I mean, that's what you learn from those situations. So that's what you want to learn from. And then here is the quotation from Appendix G, where it talks about this on page 87, where we got this information. So, and then here's the TCT chart audit form, which this is the one I would use for you guys. It comes from an accrediting organization. The one thing that's confusing about it, where it says health status and patient health needs, that's the chief complaint. So that always confuses me. So if you'll just think chief complaint when you look at this line right here, then you'll be in good shape. Nurse practitioner, she basically has to do the same thing as the physician does as far as signing off on everything. That's the keys there. And one additional thing is protocols. Make sure that you have signed protocols. 99% of the people use something called up to date. The lawyers tell me that's going to keep you guys from getting sued if you use that. The only downside to it is it's relatively expensive. It's like $400 or $500 every year. I think that's even per provider, but talk to your drug rep. They may be able to get you a free subscription to it. I've heard of that from some other people there. So, and then here's what our protocol looks like. There's nothing magical about it, but we put together something like that. You should have this type of document in your records already. If you don't, you need to pull that together. The nurses, they have the brunt of the work, and that if you've never been to a Royal Clinic, you've got to remove a lot of clutter, make sure that there's nothing expired. You'll be amazed at the things that have expiration dates on them. So you want to look through and keep everything clean. With COVID-19, the whole world has changed as far as cleaning those rooms between each patient. You want to make sure you know what the wet time is on whatever your industrial grade, hospital grade cleaner. How long does it take to kill COVID? Is it 2 minutes? Is it 3 minutes? Is it 4 minutes? You need to look at those procedures now and look at your cleaning procedures very closely and sort of reevaluate them as we go through COVID. Let's see here. Office manager, basically they're putting together the evidence binder and working on the manuals and all that. So we'll skip through. We got to move pretty fast. There are certain things you need to post in your lobby. Hours of operation in the front door, that's required by Chapter 13 of the RHC manual. You can't discriminate against people. You can't discriminate against 6'9" people. I'm sorry, you can't discriminate against me. Patient rights and a number to file for a complaint. We have little forms, little certificates that we use and they're on that website. Where you can just download those templates and fill your information in. Disclose who owns the clinic, who's the medical director, and who's the office manager. And then this interpreter sign where 15 different languages, you should have that posted somewhere as well. There's the templates for that as well. So here's a couple of what they look like. There's nothing magical about it. I just copied and pasted what the rules were. This is a good form here. This came from one of our clients that basically goes through, you should have an office meeting every month or every quarter with everybody, And these are open-ended questions, and go through these open-ended questions with your people so they know what's happening. And at least, especially if you're having a new RHC inspection, you'll want your people trained, because what will happen is you do not want them to tell what this one person told our state inspector. I don't know, and I don't care. That was her answer for that. We got 68 pages of deficiencies for that clinic. So that was no fun, believe me. So you do not want them responding that way. Conduct a mock inspection. Think about childproofing your home. Kids do crazy things. That's what you're looking at as well. And I would do, here's a form from the NARHC. This is a really good form just to do this. I would do it every quarter, is just go conduct a mock inspection just to make sure that everybody's doing what they should be doing. And before you become certified as an RHC, before that surveyor comes, you definitely have to do a mock inspection to educate and inform people what's expected of them. Here's some of the stuff that you need to do in the exam rooms. I'm running out of time here, but we won't go through all of those. But this is when you do a mock inspection, these are the sort of things that you're going to be looking for. These are basically rehashed from the J codes that you would get when you get written up. They write you up with something called a J code, and you have to respond to it. These are the typical J codes that you get. This is the big one here. I think we have a slide on this in a minute, so I'll wait till we get to the slide. Nothing underneath the patient sinks, the water sinks here. You can add paper products. I know Kate Hill said that in one of her recent sessions there, that it's okay for paper products. Now, I used to tell everybody nothing underneath the sink. And then hand washing, that is a big thing. Sharps mounted, make sure that your sharps are mounted and people can't steal the sharps containers and look for drugs in them, which I think that's crazy, but apparently people do that. This is check for expired medications every month. And Kate Hill talks about the sticker system. This is actually, I think her name is Story. This is Kate's granddaughter, who's about 3.5, 4 years old. They put the stickers on her, so she's extremely cute. But there is something called the sticker method. But the key is to remember every month you have to look for expired medications in both your emergency kit and your drug samples and injections. Anything that has a expiration date on it, you want to look for. Here's what Kate found in a survey about 7 or 8 years ago. That's all the stuff that had expiration dates on it that had expired, that they had to throw away, and they got written up for. I think this clinic got 32 pages of deficiencies for that. So Tefla, gloves, peroxide, electrodes, needles, anything that has an expiration date, have your people go through and get rid of anything that's expired. And just do a general cleanup. Okay, RHC inspection. If the surveyor shows up and you're not ready, should we send them away? Absolutely not. Just fake it till you make it. It's what I tell people. Find them a private place to work as soon as possible. Get them out of your waiting room, especially with COVID. Get them to a private place to work. Give them all these manuals that you have and give them that evidence binder and get them to working. So they're there 5 hours instead of 2 days. So that's the key there. If you're good to that person, make sure your reception is trained so she knows that there's a state surveyor that's expected and know what to do, because that's going to keep you from getting the Wicked Witch of the West versus Galinda the Good Witch. And when they do come, with their state surveyor, call your consultant, call Patty Harper, call Mark Lynn, call whoever you're working with for you to become a rural health clinic, so they know that the inspector is there. If they ask you something, you have no idea what they're talking about, just say, yeah, and then go back and ask Patty or Mark or whoever your consultant is, what are they talking about there? And typically we'll be able to get you something that you need to satisfy them or get us going in the right direction. Will they observe a patient visit? Absolutely, they're supposed to. Now, not all inspectors will do this, but they're supposed to observe the nurse practitioner, PA, physician treating a patient. It's not a HIPAA privacy regulation violation. Although what you want to do is before you go in the room, have your physician, nurse practitioner, ask the patient if it's okay for Inspector Mark to observe, and typically they're going to say yes, and then we will observe the visit. Hand washing, they will write you up if you don't wash your hands correctly. So you got to sing the happy birthday, or you don't have to sing it, but 20 seconds, don't touch the spigot. All those sort of rules apply. So you're going to have to do that. If the surveyor asks you something that you don't know the answer to, which I've been doing this 35 years, I still don't know the answer, just say, let me refer to the policy and procedure manual, and I'll get right back to you. That's perfectly fine. This is one of Kate's things here, where Kate says, I would consult policy. That's perfectly acceptable for you to say. And she's a surveyor. She's the one that's in charge of it. So I trust her judgment. And here's another Kate thing. Put out reminders for people. This is extremely important. This is the one where 22 different RHCs got a condition level deficiencies. I used to be able to tell everybody that in 35 years, I've never had anybody fail an initial inspection until 2020, when we had one nurse. Only deficiency we had in the whole survey was what she did was she had a single dose vial of lidocaine, and she dated it as if it was a multi-dose vial, that it was going to expire in 28 days after it was opened. But it was a single dose vial, had no preservative in it, and according to CMS, that is egregious. That's the word, egregious. And it's a condition level deficiency, and you fail the inspection automatically when you do that. So what you want to do is look at all of your vials. A lot of things now are single dose. It used to be multi-dose. Put your multi-dose vials in one place and your single dose vials in the other, and watch that very closely, because that one will get you failed inspection every time. 22 RHCs failed it this last year, and that's just on the TCT inspections. That's not the other ones there. So Kate makes a good point, is put these reminders out here about multi-dose vials, about lidocaine. That's the big offender that you got to watch for. So go to your lidocaine, look at it, and see if it's single dose or multi-dose, so you don't get this inspection. And look for everything there. Here's some of the survey findings here. This is from Alabama. Some of the things that they wrote us up for. Consent to treat, 9 out of 20. Like I said, those surveyors will look at 20 medical records and see how many consent to treats were missing or weren't updated within 1 year, and they will tend to write you up for that, and it's hard to fix. Here's some other ones. If you guys have been in rural clinic for a long time and you did not implement your emergency preparedness stuff, you're going to get a condition level deficiency that's going to be hard to fix within 10 days. Get started now if you've not been working on your emergency preparedness. That's a big one. Excuse me, that's a big one there. Let's go through here. In Tennessee, we didn't have the fire department. We didn't have the right fire department come out, which I don't know how we did that. And then we did not have a company come out and calibrate our EKG machine. If you do get deficiencies, it is really hard. We have a system here called Asana that sends out emails that remind you every month, every quarter, every week, you got to do this stuff, because we have to have a process to monitor your deficiencies. Let me tell you, it is a lot easier to fix things now before the state makes you do things, or TCT or the compliance team, because you have to have these monitoring systems in place, and they are no fun, let me tell you. Okay, we are finished there. Just here's your homework for getting ready for the inspection. Choose your forms if you haven't done that already, or if you're brand new. Assign your task for people to do. Clean up and discard anything out of date. Evidence binder, get that evidence binder done. Make sure you train your employees, and then do that mock inspection, and you should be ready to pass your inspection there. Okay, and all right, I have 2 minutes left, but we'll take your questions for a little bit longer. We'll finish them up. Danny, what you got for me?
Okay, the first one has a question about the professional advisory group.
Yeah.
What kind of members are required for this group, and how often do they have to meet?
They don't have to meet ever. Who's required is your medical director, your physician, a nurse practitioner, or PA, just one of those. Typically your senior nurse practitioner, senior PA, and a community representative. That's the only 3 people that are required to be on that. They're never required to meet, but they are required to sign off on your policies and procedures every 2 years, your emergency preparedness stuff every 2 years, and your program evaluation every 2 years. Those are the responsibilities of the program advisory group. Now, the best practice is is to meet every 2 years, or really to meet every year, because what business looks at itself every 2 years? That's too long to wait, but that is the minimum that you have to do to meet the RHC regulations.
Okay. The next one, if you're using employees from a temp agency to help out in reception, do you have to have an employee file on them and a BLS card since they are not clinic paid employee?
I don't know the answer to that off the top of my head. My guess is going to be that you would not, but that's just an educated guess on my part.
Okay. What is the policy on sample medications?
What is the policy on sample medications? I mean, when you give out sample medications, you're supposed to record the date, the patient name, their NDC number. There's a listing of about, I don't know, there's a bunch of stuff you gotta do that. So you're supposed to record that, and typically you can do that in your electronic health record. If you have that, where I'm trying to find where that is. I miss it right there. There we go. Sample date, patient name, medication, lot number, expiration date, amount dispensed, and NDC number is what you're supposed to record. Because of that, if you have a very busy clinic, a lot of people have just gone to vouchers and just say, okay, Mark, here's your Xarelto. For $5 a month, you're going to get Xarelto and not give out any samples. So, but that's the policy. And then the policy also is every month you've got to look for expired medications as well. Okay.
Natalie asked, can providers keep samples in their office? I don't know if maybe she's referring to the actual like physician's office.
Yeah.
I don't really know what you're asking, Natalie.
They do it all the time. Let me just tell you that. Can they? Of course they can, because they do it all the time. Is it a good practice? Probably not. So, as somebody who's employed a doctor who has got into the samples one too many times and ended up walking naked through a college thinking he was in a mall, I would definitely not recommend them keeping drug samples in their. That's a true story, by the way. I saw him on TV one night I was watching the news and like, that's my medical director. Yep, that's him. In his glory. But so absolutely, you probably should not, but they're going to keep them there, but they should be kept where all of the other drug samples are. And of course, it has to be locked, and you should have a key on it. Typically, people have like a little keypad where you just type in the keypad and you open it up, because you don't want strangers wandering in there and getting medications they shouldn't be getting their hands on. Okay.
Okay. Do you need to consent to treat on every patient or just for procedures?
You do have to have a consent to treat on every patient according to RHC rules. I know that we have lawyers that argue about that. They say, well, if that patient showed up at my clinic, they give us consent to treat by physically being here. The RHC inspectors don't really interpret it that way. They say you should have, there's a little blurb for a consent to treat that's in the Medicare rules that typically it's on the bottom of the patient information that you give the patient, and they'll sign off their consent to treat for treating them and for using their records for you guys getting paid for health insurance and all that.
Okay. Is it an RHC requirement to have sinks in all exam rooms?
It is not a requirement. No, you do not have to have a sink in every room.
Okay. In regards, going back to samples, would items like formula, diaper creams, etc., have to be documented, or is it simply medication samples?
I think it's every sample. I would think anytime you give anything to a patient, I think you're going to document that you've done it. That would be my interpretation. I've never seen anybody get written up for that and dealing with that for 35 years, but that would just be my impression of it.
Okay. Do you have any examples of closed chart reviews?
Any examples of closed chart reviews? Typically, they're done just using the same exact form that you did before. You just indicate that it was a closed chart, and you do exactly the same thing you did before. You're sort of looking, though, for different sort of trends. It's like when I look at a closed chart, if I see, this guy's 90 years old and he died of natural causes, I'm like, there's not a whole lot. Let's take and tie this thing and get it done. And then if I'm looking at, if I went to one clinic one time that we had 3 pages of people dying in that clinic, and they were all 25, 30 years old. You can quickly see there is a problem with this clinic, and we don't know what it is. Well, they were giving out opioids like it was candy, and so that clinic is now closed down. The state came in pretty much a couple of days after we did our survey and basically shut them down, because I told them, I said, there's something definitely wrong here. And they're like, oh no, there's nothing wrong. Sure enough, they got shut down. So and then look for patients that are transferring out, especially if it's one provider. I know we had this at one clinic where it was a clinic in the South, and we had a New York Bronx physician who came in acting like he was in the New York Bronx, and that didn't go over too well. People kept transferring out. So we got some sweet tea in him and trained him a little bit, and he got a lot better. So.
Okay. Does the consent to treat have to be signed every year?
It has to be signed according to the state. What they look at is it has to be signed within 1 year as well. So yes, absolutely 1 year.
And then the only other one so far is, do you have an example of the medical director's job description that you can share?
We do have one. I'll stick it. Let me write myself a note here. I will stick it on medical director, because somebody asked me that the other day. Medical director job description. Yes, we have one. I'll stick it on my website for you guys. Website. Okay. And it'll be at the same. I'll put it in the same place where the slides are. So when you're looking for them. Okay.
That's it.
All right. Well, thank you, everybody. We appreciate what you guys are doing. Y'all stay safe out there, and we appreciate it. Come see us next week when we do when Elizabeth will be doing the grant webinar, because there'll be a lot of information there you need to know. So thank y'all very much.